So thanks all for tuning in. I'm going to do my best to talk about obstetric care during COVID, how it's changed, what's the same, what's different. Of course, this cannot be entirely comprehensive because there's so much information out there, but we'll have some time at the end to ask questions as well. So, disclosures, it is possible that my cat may interrupt this presentation. She likes to paw at the door when it's shut. Otherwise, I don't have any other restrictions or disclosures, excuse me, at this time. Objectives, Tom sent these out in advance. We're going to talk about the current scientific evidence, expert opinions that shape the recommendations for OB care and COVID. Talk about current policy recommendations for outpatient clinic testing and whatnot, and then hospital triage management for suspected COVID infections. Those are kind of the rough objectives we'll get through today. So let's start with what we do know. And that's that we don't know much. There is pretty limited information from public and published scientific reports about how COVID-19 impacts pregnancy, pregnant patients, and all of obstetric care. There is actually kind of cool. The CDC puts out ASL video series, and they actually have one that I'm just kind of playing here about what the COVID-19 risk is to pregnant women. And so they actually have a plethora of videos for various diseases, illnesses that the CDC put out. So I just wanted to share this with you if you guys ever needed to use resources for patients with who are deaf or hard of hearing that use American Sign Language, they put these out. So the closed captions are showing at the bottom that we don't know whether or not they're at increased risk. We know certainly that pregnant women experience changes that can make them a little bit more immunosuppressed, increasing the risk of certain infections. But at this time, we don't have any evidence to show that pregnant patients are at any higher risk than the general population. And so she's just going to finish signing that here. So I'll just let it play for another like 20 seconds. So that is available to you guys as a resource, but we will move on right now. Here are hyperlinks to all of the resources that I obtained a lot of my information from, CDC, WHO, ACOG, AAFP, our own DFMCH OB Hub, the OB-GYN UConnect page, and there's going to be many more sites that are linked in with all of the notes so that you'll have access to those. The very minimal scientific data that we do have had 6 positive women that had their amniotic fluid or cord blood tested, and it was a very small number of cases, but we did not see any evidence of vertical transmission, which is consistent with what we see for other common respiratory viral illnesses, such as influenza in pregnancy. We don't have evidence of vertical transmission, still the kind of aerosolized particles with that. So we're going to walk through a case here. This is Shireen. She's 37 years old. She's a G2P0010. She is at 38 weeks and 0 days by LMP, consistent with a first trimester ultrasound. You are seeing her in clinic today for an OB checkup. Her pregnancy has only been complicated by AMA and iron deficiency anemia. Her last checkup was a telemed call 1 week ago. So already we're noticing something that's a little bit different compared to what we would do for OB care a couple of months ago. She had a telemedicine call. So this is consistent with what our own DFMCH has put out about modifying the prenatal visit schedule. As you can see here, we have taken a whole host of what has typically been an office visit and replaced it with recommendations for telemedicine visits. The idea behind this, trying to minimize healthcare contact and asymptomatic or even symptomatic vector spreading that could further spread the COVID-19 virus. You will notice that ACOG or maybe you haven't noticed, but ACOG has actually published like a 30-page document about different recommendations for ways to adapt prenatal visit schedules. There, both locally and nationally, are going to be variations. There's not a way to be consistent about this because it needs to be intentional and taking into account different health systems, different access to resources, different patient populations. And so this is kind of what we've put out and still encouraged our providers to say, hey, this is still adaptable. You can change it to fit the needs of your patients if they're higher risk or don't have the same resources. So this is on the DFMCH OB Provider Hub for you to access, and kind of has been implemented. So we have a quick little poll everywhere here. Just grab your phone and just tell me real quick, what's been your experience with OB telemedicine visits so far? In a perfect world, your responses will show up on the screen, but who knows? So I'll just give it a couple of seconds if you guys just want to take a moment and let me know how it's been going. A breeze. Oh, so it does work. We have one response. Great. Overall well for uncomplicated pregnancies. That's good. So maybe that means that for complicated pregnancies, it's been a little bit more difficult. Maybe the so do was supposed to be another so. Got it. Okay. Some patient confusion, some difficulties with workflow rescheduling. Absolutely. How do we kind of communicate that not only to patients, but to our ESRs and our MAs? Difficult to coordinate for patients requiring many consults or those who need to talk to specialists. Totally agree. Uh-huh. Yeah. They like being able to hear the baby. Certainly is hard to palpate a fundus. Maybe if someone's ever done a video visit, we could kind of talk them through how to measure the fundus. I'm not sure, but awesome. Cool. Well, thanks everyone for kind of just sharing your thoughts out about this. Yeah, anxious, wondering if care's not as good. Absolutely. We will move on. All right. So she is here for your checkup. She's been feeling some intermittent Braxton-Hicks contractions, no vaginal bleeding, no discharge, good fetal movement, vital signs all normal, afebrile, good blood pressure. And so you guys kind of talk a little bit today about how she's going to have her baby. She is, like I said, 37, and so is AMA. And so you guys talk a little bit about induction at 39 weeks. And you decide that you're going to schedule an induction for 39 weeks in one day because that's what your local hospital had availability. And you're not going to have any additional appointments prior to the induction because that's about 1 week from now. She's at 38 weeks today. And then you discuss a little bit of anticipatory guidance about what things are going to look like in a changed COVID world. Hospitals are kind of reserving the right to move or cancel elective inductions. This should not be changing medically indicated inductions. We are all familiar with the limit on support persons. And for different hospitals, that may or may not include a doula. At Meriter, a doula is considered hospital personnel, so they're included. At St. Mary's, they are not. So the doula would have to be your one asymptomatic support person. Of course, New York made the news when certain hospitals were restricting women to having no support persons. And then governor's executive order overrode that, fortunately. And there was lots of discussion on how could we implement something that we don't have any data on versus knowing that having a support person can significantly improve outcomes for both moms and for deliveries and for patients. The OB provider team may not look the same. We're not going in for continuity deliveries because we're trying to minimize healthcare touches. So, I'm counseling her at this appointment that I'm probably not going to be the one there. It may be one of my colleagues. And we also talk a little bit about the universal COVID screening that's happening at some hospitals and how you can expect that your healthcare providers will be wearing PPE. These are a few things that are different. Pain management options have changed. Water births are not being offered, and ACOG has issued a statement about nitrous oxide being the concern for a highly aerosolized product that should not necessarily be an option. So that has been restricted. There's been ebbs and flows on whether or not tubal ligations are happening, at least at Meriter, they are back on. This was out of an effort to conserve PPE, not saying that tubal ligations weren't essential, but rather it was a procedure, a surgical procedure that would require many people to have lots of PPE use. And so trying to conserve PPE was important. So now that it seems like things are a little bit more stable, they've reinstated that. Timing of hospital discharge has changed. Trying to expedite discharges 24 hours post vaginal delivery, 48 hours post C-section. That looks different. And then for male circumcisions, they've put up policies about not observing in the nursery to try to minimize different people coming into the nursery settings and keeping them, quote unquote, clean. So that's kind of a list of 8 changes already to briefly summarize. 3 days later, she calls the clinic. She now has symptoms of a fever to 101.3, a cough, she's congested, sore throat. She doesn't have any known COVID-19 positive contacts, but her fiance is a nurse practitioner at a SNF, and she did go to the grocery store 4 days ago. She wore a mask. Otherwise, she's been at home. Of course, you all know we're in the community spread phase, so it doesn't necessarily matter if she did or didn't have a known COVID contact. There are certainly kind of risk factors just by being out and about, despite her best efforts. So this is a phone call we get. What do we do? Well, as of April 20th, UW is now aligned with the testing guidance from the Wisconsin Department of Health Services, where COVID testing should happen for all symptomatic patients, even mild. And here is now our comprehensive list of acute symptoms that would prompt testing. And actually, as of yesterday afternoon, we now include vomiting and diarrhea in this entire list. So to be consistent with the recommendations, our patient should get COVID tested. She has symptoms present, so we would route to the UW COVID nursing pool, and they would help coordinate testing of our patient. So I'm not entirely sure what the supposed turnaround time is, but we'll say 4 hours go by and we have our results. Shireen's test came back negative for COVID-19. So we call her and we discuss, hey, this was a negative test, but she's wondering, gosh, should I still have my induction at 39 weeks and 1? Should I consider moving it, or should I keep the appointment as scheduled? And so here I'm referencing ACOG, that in general, the timing of delivery should not be dictated by maternal COVID, but I've bolded for suspected or confirmed cases in the 3rd trimester, it is reasonable to attempt to postpone delivery until a negative test result is obtained or quarantine status is lifted. So that is kind of what they are saying is, if you have the safety to be able to allow the pregnant patient to get a little bit better, a little bit less asymptomatic, or a little bit less symptomatic, then that could be an option. But in general, we try to keep things as is. So we kind of talk to her, and through shared decision making, even though it's a negative COVID test, she now wants to delay, and so we're going to schedule the induction now at 40 weeks instead of the induction at 39 and 1. But then 4 days later, she calls clinic at 39 weeks with signs of labor. So your nursing staff expertly sends her to OB triage. Just so happens that the resident on service happens to be a part of her OB care team. So yay, we were able to get some continuity in that. Her URI symptoms have improved. She only has a mild cough remaining. But now per protocol, she is getting her, like we said, universal COVID screening swab. And oh my goodness gracious, her COVID-19 came back positive. Crap. So we now are, wondering, gosh, was the first test negative? Did she somehow pick it up in between there? Maybe from her clinic visit? We don't know, but she now has this COVID positive test result. I'm going to talk a little bit about some false negative tests here. The president of the AAFP was quoted saying that there just hasn't been time to test the PCR testing before using them in the field. There is a report that came out from studies in China showing up to a 30% false negative rate, primarily due to collection concerns, so maybe not necessarily getting far enough back in the nasopharynx. This published or is not yet published. It's kind of a pre-release. It's not yet peer reviewed. And so, and again, this is not anything out of US or nationally. So there's kind of a little bit of a caveat. But of course, I think many of us wouldn't be surprised to know that there's going to be some false negative rate. And so some health institutions have actually made the decision because of that to do two-step testing. So this is an algorithm about COVID testing from UCLA that actually has in place like I said, a two-step testing where there is, if symptomatic and a high suspicion, they would recommend retesting for COVID, which is kind of what happened here. Just by nature of having two tests from her symptoms to the screening on admission. But other again institutions have implemented that as policy. So it's just kind of an interesting different way of doing things and kind of merits discussion on should everyone be doing that or not. And I think it really comes down to what resources do we have. If we barely have enough tests to be able to test everyone the first time, doing two-step tier testing, it's hard to know if that makes the most sense. So we talked to her a little bit about during the hospitalization, she can expect that all of our healthcare providers will be wearing PPE, face shields, goggles, an N95 mask or a PAPR, gowns and gloves because of this positive COVID testing. This is a pre-assessment poll from the AFP case that kind of pertains to our case here. So I pulled this in. Grab your phones out again. We'll give you a few minutes to read through this. You are covering labor and delivery and currently have one negative pressure room available. Your hospital has a shortage of N95 masks. Choose the scenario below that describes the best way to manage your scarce resources while maximizing patient and staff safety. I'll let you guys read through the responses and send in your text of A, B, C, D, or E. Great. So I have no idea how many responses we have back in, but we'll just kind of look at the responses here. People are seeming to really like A, and then some amount are also seeming to like C. I think it's also kind of a little bit of a not trick question, but certainly this can change depending on the hospital that you're a part of. And so, COVID positive patients and active labor should be in negative pressure rooms. We would want to cluster care, and we would want to make sure that those providers who are caring for COVID positive patients have access to those limited N95 masks. So that would certainly be correct. Meritor has said that so long as there isn't a shortage, that staff could wear N95 masks during the second stage of labor, but they did kind of reserve the right to be able to change that policy if there are any concerns about shortages of N95 masks. So we'll move on from here. Again, I pulled that pre-assessment question from the AAFP's COVID maternity care CME case, which Lidri Sang sent out, and Jency Carlson also sent out information about. I would strongly encourage you all to take a look at this and go through it. It's excellent. There are kind of three different parts to it. There's the coronavirus isolation. Then there is a case study part 1 and case study part 2. And you can kind of listen to those in three different sections. So I think that I try not to cover a lot of the material that is addressed in these because one, we only have so much time, and two, they did such a great job, I couldn't even compare. So we'll jump back to our case here. So Shireen delivers a healthy baby boy. She and her partner do not want a circumcision, so they are okay with not being able to go to the nursery to watch. She does choose to breastfeed while wearing a mask. I'm only going to briefly comment on this because I believe Anne Eglash is going to be doing a talk or discussion about breastfeeding. But this has kind of been very variable. We had conflicting recommendations from the CDC. AAFP came out with a statement that said it should be shared decision making. WHO from the very beginning said a woman with COVID-19 should be supported to breastfeed safely, hold her newborn skin to skin, and share a room with her baby. So they were very explicit with that, versus the CDC was initially recommending that you separate mom and baby. And again, there was kind of a lot of pushback of, hey, we have a ton of evidence saying that there are many, many benefits to the breastfeeding skin to skin and room sharing. And we don't necessarily have the evidence that we need to completely separate out. But certainly each parent is going to be an individual, and it should be truly shared decision making about whether or not you breastfeed or how to safely breastfeed within that. So here's your summary.
Just say one more thing about that.
Yeah.
This is Jency in Verona. I just have, some of the policy changes that came through just this week from the AAP and the CDC. Really, one of the things that we need to think about as family physicians is the role that advocacy of our partners played in making those guidelines change. So I know Ann Eaglesh in particular, but there were many, many people who played a strong role in advocacy with just what you're talking about. What do we have solid evidence for, and are we doing something that's potentially very destructive without an evidence base for it? And so I just want to speak to in a time where we don't have a lot of evidence and there's evolving guidelines, the role that we all played in advocating for our patients, both at our local hospital systems level, which we talked many, many times about this recommendation, and at a national level.
Yes, absolutely. Thank you. That has truly been a huge influencing factor for many of the different pieces in OB care is healthcare workers, docs, nurses being patient advocates and advocating for policy changes on their behalf. So wonderful point. I'm including this picture because I just thought it was hilarious and adorable that they gave a little face shield to this baby. I am not in any way, shape, or form endorsing that babies need to be face shielded, but gosh, it's just cute. So there's your dose of cuteness for the day. So back to Shireen. She is discharged home at 28 hours. Baby boy Cheyenne will have a weight check brought in by his parent in 2 days to the clinic. Shireen's made the decision that she'll stay home and let her partner, her fiance, bring in the baby there. So in summary, the biggest kind of takeaway that I want you all to hear loud and clear is what was announced by this joint position statement from ACOG, AAFP, American College of Nurse Midwives, and the Society for Maternal Fetal Medicine, is that we still absolutely need to have patient-centered care at the front and center of caring for our pregnant patients during the COVID-19 pandemic. And it may not seem like there was a ton of substance to this, but I think really keeping this at its core is how we kind of frame decisions about the management changes for our pregnant patients. So, these are our patients. These are the people we're taking care of, and it's still, we want to make sure that they're healthy, that baby's healthy, that we as their healthcare providers are healthy, and that we're still treating them as human beings. You may have already realized that having masks and visors on, just things feel a little bit like depersonalized. And so how can we try to move past that and still provide good and safe care? So their statement said, "We stand in solidarity with our patients and are committed to working tirelessly to deliver evidence-based, respectful, patient-centered care to ensure parents and their families are supported during this time of pandemic." And I think it's, again, just really important to make sure that we're kind of keeping that at its core as we offer ongoing care to our patients. Just commenting a little bit on speculations that, oh my gosh, people have been at home. Is there going to be this baby boom in the near future? So there's lots of articles and headlines in the media. Will coronavirus have a baby boom? Never mind a baby boom. Here's why it's dangerous to conceive. COVID could lead to millions of unintended pregnancies. And this cute little tweet here by Keith Smith. Are we all agreed that babies born 9 months after COVID are going to be called coronials? And in 2033, 2034, they'll all become quarantines, hashtag dad jokes. So pretty adorable. There are some different kind of theories out there. Of course, only time will tell. One of them is this article. It's a really lovely econometric article that analyzes fertility effects of hurricanes on birth. The takeaway is there was kind of a more complex relationship between fertility and catastrophe than maybe is described in the media. They did find that as storm severity progressed from less severe to more severe, fertility, the relationship decreased from positive to negative, meaning the more severe the storm, the less likely there was and may actually have had a negative effect on fertility. So less babies were being born 9 months later. So if it was a hurricane warning and there was actually a hurricane 9 months afterwards, they saw less for fertility and babies being born. This seemed to be more so in couples who have had at least one child previously. So for the first child, it was pretty inelastic, meaning whether or not they were going to have a baby, kind of stayed the same and wasn't super manipulated by the catastrophe versus parents or families who'd had multiple or who'd had previous kids tended to be a little bit more influenced by storm severity. So of course, this is talking about hurricane warnings, isn't in any way, shape, or form COVID, but that is some of the data that's out there that is informing how we think about this. And so there's some speculation that there won't be as much of a baby boom because of the severity and how dramatic and the strife that's really been associated with this. This is really at a national level, and I think it's important to think about things at a worldwide level. This is out of United Nations talking about serious concerns for increases of violence, child marriage, female genital mutilation, unintended pregnancies due to the COVID pandemic because of diminished choice. And that's already very present for women in all countries. But this is really going to disrupt family planning services. And there's a lot of concern about the vulnerability of women and, in throughout the world. And that then itself may be a reason why pregnancies increases because they don't have access to things or it was already limited. And so it's even more restricted going forward. So just kind of two perspectives to think about this. So baby boom, who knows? Time will tell. I'm sure it'll be different in different regions, but something I just wanted to kind of comment on because I know it's been talked about. Jumping back to our objectives, so hopefully we were able to learn a little bit about some of the science that's out there for recommendations of care. We talked about testing and how to evaluate patients at the clinic level for prenatal care. And then we talked about hospital triage and how things look a little bit different in the hospital for obstetric patients during COVID. Again, strongly encourage you guys to do the AAFP maternity care case because that really digs into hospital management and I think has some awesome points that I didn't have time to bring up here. So go ahead and do that. And I think I have, about 20-ish minutes for questions. So yeah, what do you got?
Hi, Ali. This is Patricia. Thank you for a wonderful presentation. I have not been at the hospital. I have been at the clinic, but I know that many of you have been, and I wanted to know what your experience has been with patients, how receptive they have been or not, what their concerns have been, and if we actually have been managing many patients or how many patients with COVID for the OB floors.
Yeah, great question. So I think definitely concerns from patients that I have heard and continue to hear is, am I going to have the support? Certainly, there, especially when New York was limiting it to zero support people, there was a lot of anxiety about the possibility of having to deliver a baby without anyone that you know, including your own doctor. In the room. And I think that since New York's policy reversed and Merida and St. Mary's have stood strong in their recommendations to have a person, I think some of those fears and anxieties have been alleviated, but that was definitely one of the ones at the forefront. I think some other concerns were about for patients that were struggling with breastfeeding or needed to supplement, not because they were COVID positive, just because of, what can normally happen with the difficulties of feeding the baby after delivery. Fears about not being able to access formula because people were hoarding or buying up. And there were news stories about how you couldn't purchase formula. So there was certainly stress and anxiety about going home, kind of counterbalanced with the desire to get out of the hospital as soon as possible to minimize any, kind of healthcare contacts at that point. So those are some of the things. I'm sure there's many more, but those are kind of some of the concerns that have come up from my work at the hospital. I did not care for any COVID positive patients. I think Merida just cared for one the week that I was kind of coming off of the rotation. Not sure if anyone who's currently on is on the line and would be able to speak to that. But I know there have been at least one kind of present there.
This is Jency. I can't speak to the service caring for COVID positive patients. Like Ali said, the volume has actually been pretty low as far as COVID positivity on labor and delivery in general. Interestingly, one of the things that has been an unintended consequence is that there's been a really dramatic rise in pediatric readmissions for weight and bilirubin issues. So that's something that we are actively talking about with the peds hospitalists and the community pediatricians as well, but AFCH has seen a pretty significant rise in readmission. Actually, the number that they quoted this week was actually a fourfold rise. So huge, and people are going home early. So exploring the root cause of that is something that we're doing.
Thanks, Jency. Other questions?
Since nobody's asking, I ask again. So, going forward, yesterday we heard that we are trying to go back to our regular routine, which will be people that were before on call will be on call or whatever in June or so. And the question that I made yesterday in the call that I want to make here too is that what are obviously we have standard measures that we're going to do to try to keep our cells and our patients healthy so that we don't, increase the risk of them getting the virus. But now we're going back to, I could have been in the clinic with someone that could have been at risk. And now I'm going to go in the hospital and be in the OB floor or being, with my patient. So my concern is that I don't think that a lot of things have changed. If at all, more have been at risk and more can be already infected with the virus and not know that we have been or we are. So again, we know that even if the patient and us are wearing a mask, that is not a guarantee of not contaminating. So I wonder, what else are we going to do now that we are trying to go back into the regular flow?
Yeah. Great question. I think a lot of it is to rely on our ability to get fast and comprehensive testing to as many people as we can to help be able to resume a continuity practice. I do think that we are maintaining kind of the siloed residents and faculty for a little bit longer beyond the clinics opening up a little bit more, because we do want to be very intentional about how we do that, because you're right, the risk is still present. And so that is kind of why I believe that the OB kind of block schedule for faculty is being, continuing through June. That may or may not change depending on how our resources for testing and how, numbers coming back for community spread look in the next few weeks. Jency, I'm not sure if you have more to add to that.
I mean, Patricia, I think it's a really good question. And I think that I don't have an answer to this question. I think part of why we've talked about not returning to our previous schedule for OB until June 13th is that we need the time to think about that, both, as leaders and as a group. I think I'm very open to hearing both opinions from our local experts. We will definitely be talking to OB before we make decisions, because right now our model is in line with OB. We'll be definitely talking to, Lee and other people who have more expertise in OB than I do in particular. And then people like, John Tempty and our leaders who know this virus better than I do. I think they're, yep. I mean, I think that, as Val's pointing out, I think, the safety in particular of the newborns, I think, is of utmost concern. And I don't know that we're going to be flying blind when it comes to evidence. So we're going to be having to make our best judgment based on what's happening across the country. We're hoping to stagger far enough behind California and New York to see what they do. So we have the advantage of being in the Midwest, of being able to stagger behind some of these other places. But I am really open to everyone's input as far as how do we do this safely. I definitely want to get us back to continuity care as soon as we can. That is one of our prime tenets in family medicine. And I know that our patients are longing for that. And I want to do it safely. So I think I don't have an answer yet.
And also, sorry, I would like some direction on what to communicate to the community, because I am frequently in the radio and talking to my community, including next Monday. And I was thinking how the family structure might be different in some of the communities. So for example, I know that in many households, there is the grandma that is also providing care to the newborn. And we have been trying to isolate older adults, but how is this going to look with a new family member in the household? Should we be cocooning the babies a little bit more like we are doing with the older population, and having the older population provide a little bit more of the care compared to the younger population that used to help more, the other siblings or whatever? So I have been thinking a lot about that, on how to communicate that to our different communities that might have a different face than the community at large. So I think that's why I really was looking forward to this presentation and this advice before my radio on Monday.
I think, Patricia, we need your expertise there as well about what we can do. I mean, we're going to be to a certain degree making this up as we go, using the information that we have. I think one of the things that I have talked with families about a lot, as far as how are you concerned, is that there's the virus itself concern, which there's mixed evidence in pediatrics. There's some evidence about severe disease. There's some evidence about less severe disease. The one thing that we do know is that if a baby gets a fever within the first month of life, they buy themselves a hospitalization and a sepsis evaluation. And so, the things that we can encourage people to do to cocoon that newborn during a bad flu season only makes sense to encourage people to do during this COVID epidemic. And unlike a flu season, we can't say things like everyone should have their flu shot before they're around the baby. There's no COVID shot yet. So, we're in a time period where I think each family structure may need to be thought about a little bit differently, and we're just going to have to use our best medical judgment to think about how we minimize that risk, because there's not evidence. So So we have to use our best judgment there. That's something that we've definitely been talking with families about. I've been encouraging cocooning the newborn as much as possible. I think Allie might have mentioned it when I had to step out on a call, but there's an excellent series on NPR from a couple out in New York who had a baby during this time period, and talking about, they interviewed them at various points during this. And one of the points that they interviewed them at is that the mom ended up getting COVID-19 and the dad is providing all of the care to the newborn at this point, isolated in their house, and what that has meant and how it's different than what they had anticipated. And we are all having to figure it out. And I think we can only just get as much information as we can and then make our best medical judgments based on that.
A little thing from Tom. I have to sign off in regard for. Yeah. So Tom's just kind of saying about home blood pressure cuffs, and that has certainly been something that we've been trying to advocate for. I think it's just hard to figure out how to get everyone blood pressure cuffs. So yeah, totally. Thanks, Tom. Other questions?
Again, since nobody talks, I'll talk. I was thinking about centering the other day and how that is going to be difficult to do. And now that we have been doing all these wonderful presentations online, I wonder if there will be some room to try to do some education, over Zoom or WebEx, that it will be more convenient because patients don't have to go anywhere. They can still ask their questions. So I wonder how would that work and if that has been thought of.
Yeah, I've definitely seen, I know that Harambe Village has been doing some online kind of group visits. They would do their monthly meetings. And so they are a local community group that has kind of transitioned to online. So it would be, interesting to see how that's been going, to see if we can kind of learn from their experiences with that. I've also seen a couple of the breastfeeding alliances kind of have call-in chats and kind of video check-ins. So absolutely, I think that would be something that is already being done in our community and could be a model that we kind of look towards to shape centering in our facility. I think being mindful of using platforms that are HIPAA compliant and whatnot is going to be an important piece of that and may be a limiting factor as we go forward. But yeah, absolutely. I think that is certainly the centering we know has benefits to it. So are there ways to continue centering with minimizing healthcare contacts? So those are just kind of what I am aware of is already going on, Patricia, and I could certainly work with you to reach out and see how it's been working.
Another thing that's been going on is both hospitals' birthing classes are virtual now. So that link is on the DFMCH hub. Maggie shared those with us, and I got feedback from a patient that they were like, even if it wasn't COVID times, I would have preferred to do this virtually. So I think that at least for that N of one, they really felt like the virtual birthing classes were useful.
Other questions?
Again, no question. Then I will say just thank you to everyone because this has been amazing to see how as a group we have organized to provide the care that our patients needed. Obviously, the ones that were at the hospitals and in the front, our residents have been amazing with the stories they have been telling me about the MICU and COVID patients. And then our partners on OB, thank you for taking care of the next generation, because as I thought of this being like, end of life, like, oh, this is the work kind of thing. Let's save the new generation. Let's cocoon the pregnant and the little babies. It has been amazing to see the work that you have been doing. And obviously the ones that stay behind at the clinics, trying to keep with providing the care to the other patients that we have, and not our administrators being so creative with solutions to flaws in the clinic and how we could see telemed and video and how we could coordinate. I think that one very good thing that I have seen come out of this is the team effort that we all have and how we have all kind of come together to provide the care and to do these presentations that are awesome, because I'm sure you had to put it on the fly and you did wonderfully, and other presentations that we have had about COVID and other things. So I just wanted to really thank everyone for coming together.
Ellie, I have a question comment about your presentation. Lou.
Yeah.
Yeah, great presentation. I joined like 5 minutes ago and ran through your slides. So I feel like I now know, Kung Fu or something. I just got all your stuff. We just, limited data have been seeing fewer entry prenatal visits than often we do, but we've only had like 3 data points. This is the northeast end of it. And so we have various theories about it. One is there's no trend here. The other is when patients call and find out our building is closed and they aren't particularly strongly attached to the clinic, they may figure out other places to go. And the other is what I call the avoidance of care issue, which certainly has been true for other conditions. People sit home with their chest pain. I'm wondering if we're going to start seeing entry prenatal visits at more like 16 weeks, or people are just going to not rush to the doctor at 8 weeks. So it's just something to consider as we go forward. Not seeing people is not necessarily a good thing. We know early entry into prenatal care is associated with better outcomes.
Yeah. I mean, anecdotally, I have had one that was a new to established care at our clinic, and was like maybe around like 22 weeks, and it was like, oh well, I didn't want to come in because I was worried about getting sick, and so again, that's just kind of like an N of one, but I certainly have heard that echoed exactly what you're saying from a patient personally. So that certainly could be a factor. Yeah, I mean, I think we're going to see all the theories of there's going to be more babies, there's going to be less babies, there's going to be, babies or pregnant patients that come to care later. We're going to see probably all of those things, and it'll be interesting to kind of know what predominates and what's the actual trend that we see.
Will we see more, ruptured ectopic pregnancies, or things that people would normally pick up with earlier entry? It's just, I don't know what the data will show when the smoke clears.
Yeah. And I think it'll look different for different locations. I think internationally versus nationally is, I'm not sure if you turned into that, but kind of the slides 46, 47 kind of comment on how things could look a little bit different for different populations and cultures. So I'll be interested to know how everything turns out, 9, 12, 15 months from now from a variety of perspectives. Yeah.
The other thing that I can tell you about that I have been getting at least 2 cases is people that were actually just visiting here that got stuck in here. I have one particular woman that is more advanced now that has not been able to get prenatal care because she was just here visiting her husband that is doing some work here. And now she's going to have to stay basically. And it has been very challenging because, again, she's just kind of new to the area. They don't even have a local phone number because they came from Mexico, so they have their phones from Mexico. So I have been trying to see how is that I can help them so that they can start prenatal care with us at Wingra. But another family like that too, that they were just here temporarily and now they are going to have to stay. So I think we're going to start seeing more and more of those cases as well.
Yeah, absolutely. Good. Any other questions, comments, feedback? wrapping up here in the next few minutes, but happy to answer them now or send me a message separately. Want to make sure you guys are having your questions answered and feel like you know what's going on, even though no one really does. So I think I will make the decision to wrap it up here. Thank you all so much for tuning in. I hope that it was helpful. I know kind of quite broad and there's a lot of information. So again, use the links that I've embedded in there. Do some research, do the AAFP case, and I hope you all have a great rest of your day. Thank you.